So B12 folate deficiency, pretty straightforward. I lack B12, I lack folate, messes up my DNA synthesis. I end up with these large cells, macrocytic. Okay, good? Am I good? If I'm deficient in B12, how am I going to treat it? I give you B12. I'm deficient in folate, I give you folate. Be able to look at your lab and distinguish between the two. Be able to look at presentation and distinguish between the two. All right, moving on to normocytic anemias. Good times. All right, normocytic. What's the size of our cells? Normal, which is what? All right, 10 class. Got this. Yes. All right. Usual labs, right? Nothing new there. CBC. Right. What are we homing in our CBC? Hemoglobin, grit, RBC, right? Are they anemic or not, right? Your retic count's telling you what? Hemolysis, hemorrhage, or not. Peripheral smear. What kind of stuff can you see in a peripheral smear? Hypersegmented neutrophils, macrovalocytes. Right. CMP. What's a CMP? Complete metabolic panel, chemistry panel, right? So some of the key things we'll look at for some of the disease disorders. And then your LDH, haptoglobin, and bilirubin are markers of what? Hemolysis. All right. Sweet. Here we go. Approach. You guys have seen this before. All right. Yep. They're anemic. I take a look at my retic count in this case. Oh, I got some retic counts up. I look at my markers for hemolysis. If I got them, yep, it's hemolysis. If not, I'm worried about a hemorrhage. In case my retic count is normal, come over, I look at my indices. Again, we're dealing with normocytic. Retics, and you can follow this pathway down, right? Increased red cell production, trying to catch up. My markers for hemolysis, yes or no? Hemorrhage or hemolysis? Normal or decreased, so you can take a look here, right? So again, iron, we talked about iron as being what? Microcytic, hypochromic. Depends on where you are in the disease process. Are you so early in the disease process, right, that your cells are still appearing normal? So early on in a iron deficiency anemia, right, your cells could still appear normal. All right, there we go. Normal RBCs. Causes, inflammation. Right? Is it a chronic inflammatory position like a RA? They have some underlying infectious process going on, and then malignancies. Chronic kidney disease. What's the kidney's association with anemia? EPO. Right? And then obviously acute blood loss. Right. So this is the stuff we're going to talk about. Hereditary spherocytosis, G6PD deficiency, sickle, and then the autoimmune stuff, and then we'll hit the aplastic anemia. Oh yeah, we promised when we talk about anemia, chronic disease, and inflammation. Right. So, diagnosis of exclusion, second most common cause of anemia. There's the pathways. We talked about this a little bit before, right? So, inflammatory process increases my hepcidin. Hepcidin does what? Closes the door to iron. So my iron decreases. Usual type of symptoms we associate with anemia: fatigue, weakness, shortness of breath. Sure. There it is, your hepcidin, right? Produced by the liver. Infection, inflammation, and malignancy. So let's take a pause for this for a little bit, because a lot of people have issues with this. So what the body is trying to do, right? So by increasing your hepcidin levels, you're decreasing the body's access to iron. Infection, bacteria loves iron. In order for bacteria to replicate and do everything it needs to do, it needs iron. So the body is saying, I'm going to be smarter than you with infection. I'm going to cut your access to iron to try to keep this infection down, right? It's a defense mechanism. inflammatory states, malignancy, high turnover states, right? What happens in cancer? Generating cells out of control, right? You're proliferating a bunch of cells. The body needs iron to proliferate all those cells. So the body is saying that if I keep the iron away from you, I can slow this down, right? It's a defense mechanism for the body. Hypoxemia, yep, increased demand, right? Good. All right. There's your pathways again, right? Increase hepcidin, decrease in the iron. In the case of other cytokines, decrease in EPO production leads to decrease in erythropoiesis. Again, hepcidin, problem child here, right? But really, for the body, it's thinking it's doing the right thing, right? I'm going to keep iron away so this infection can't continue to spread and get out of control. I'm going to keep iron away to slow down this cancer. Right? There you go. Infection, inflammation, malignancies. Lab findings. Easy day. Dealing with a normocytic anemia, done. You get low iron. Why low iron? Hepcidin, right? Hepcidin upregulates. You get a low TIBC. Ferritin, normal to high. So what's the ferritin? Storage, right? So again, what's happening here, the hepcidin is locking that iron into storage. Right, so whatever iron you had in storage, instead of the body getting access to it, it's coming in back into circulation, it's remaining in storage. Because the body's trying to keep iron away, right, from whatever disease process is going on. So your ferritin levels stay normal and can potentially elevate a little bit. Transferrin. What's your transferrin? Transport, right? So again, the body doesn't want more iron. I say, how do I keep iron away? What happens to transferrin iron deficiency anemia? Goes up. Right? When the body's iron deficient, it wants more iron, so it increases your transferrin. So that's where people get hung up on a little bit. And we'll see it on a slide, and hopefully it'll make more sense to you. So diagnosis, low, yep. Iron's low because of the hepcidin. Ferritin stays normal to high because again, it's locking that ferritin that was in storage. It's keeping it in storage. It's not allowing it to get access to the bloodstream, to get out. Right? And the body says, you know what, I don't want more iron, so I don't produce more transferrin. Right? Anemia of chronic disease. Iron low. Again, ferritin normal to elevated because it's locking that ferritin in storage. It's not letting it out into circulation. Your transferrin stays normal to low because the body says, I don't want to take on more. I'm already trying to keep the iron away. All right. Treat the underlying. Yep. Whatever the problem set is, if I treat that problem set that's causing this, then the anemia should get better. In severe cases, do they get so anemic that they need a transfusion to help them through? Is it a kidney set problem that I need to get them on some ESA stuff to stimulate, right? Erythropoietin. Iron supplementation, generally not effective. Why would iron not do anything for you? Yeah, because the body doesn't want it, right? The body's already trying to keep the iron out of the system. Right? It's not letting it in through the duodenum, right? The hepcidin's upregulated, right? It's locked the iron that's stored as ferritin, it's locked it in storage, right? So giving it more iron isn't going to do anything for it. It's not going to fix the anemia. Okay, moving on. Anemia of chronic kidney disease. This one you guys can wrap your head around relatively easy. Kidney produces what in relation to blood? EPO, right? Kidney isn't working so well, and I'm not producing enough EPO. There's your problem set. What's your markers of renal function in your chem panel? GFR. So BUN and creatinine, right? And that's the test you're going to get back. You're going to get back a BUN and a creatinine, right? And you can say, hey, my kidneys are doing good or not. Best marker is your GFR. Their GFR like was tanked. States of kidney disease, right? You guys don't have this slide. I know because I just threw it in here right before I got here. But again, this is just to kind of show, right? Your GFR. 90 or above, solid. Right? Severe, get down below 30. Yeah, might not be producing so much people. Right? Kidney's not doing so well. Alright, and there's the mechanism, right? Again, receptors in the kidneys detect the low oxygen level, says, oh crap, I need to do something about this. Spits out EPO, right? Bone marrow starts cranking out more cells. And if you ever wonder all the stuff that the kidney plays a role in, right? Pretty impressive. But for us, the one we're centered on is erythropoietin production. Straightforward enough? Everybody good with chronic kidney disease? All right, liver. Plays a role in synthesis and clearance of proteins, yes. End-stage liver disease, cirrhosis, yes. So what does the liver do in terms of red blood cells? What does the liver do in terms of this whole process here? Recycle iron, right? So storage capacity, you also store all that ferritin, the iron storage there. It also plays a role in our lipid metabolism. What's our RBC membranes? Some form of lipids. Right? So if it's not producing the lipids normal, it's not producing normal lipids, and I have issues with my RBC membranes, then maybe my cells don't survive as long. Maybe they're not as effective. So liver plays a significant role. Sequestration of RBCs, the spleen, yes. Increased risk of bleeding. Again, and we'll talk about this in some of the other disease processes, but the liver produces all your coagulation factors, right? Produces thrombopoietin, platelets, so obviously if not doing its job, you may have a problem. And we don't talk about this a whole lot, but the liver does produce some erythropoietin, relatively small amounts, right? And it's also another site of extramedullary hematopoiesis. So if my liver is not doing all the things it's supposed to do, it's not doing it as well as it's supposed to do, it can lead to anemia. Management, sure, treat underlying stuff, yes. RBC infusions is absolutely needed. Again, iron. Any questions on that? Aplastic anemia. No questions? What's that? What's aplastic anemia? Nothing, right? Bone marrow failure, right? So what does that mean for my cell lines? All your cell lines, right? So the key, and we'll talk about this, is pancytopenia. Right? Pancytopenia. RBCs, WBCs, platelets, all below normal. All right, there it is. Rare, life-threatening character, bone marrow failure, decrease in all cell lines. Again, it's anemia, so you get the fatigue, shortness of breath. Why do it bruising? Platelets. Bleeding, platelets. Why infection? Right. No neutrophils, right? There is bone marrow, right? And this is the classic presentation, the hypocellular or the hypoplastic bone marrow. Right? It's just void of all the cells and that's not producing anything. Major cause is autoimmune or idiopathic. This kind of happens. And you can see there's certain infectious processes that can kick this off. EBV being the big one. And then cytotoxic drugs and radiation. Again, no treatment's benign, and certainly not cancer treatments, right? Cytotoxic drugs, radiation have side effects. There we go, drugs. This is why every time I put somebody on something like my heart skips a beat, right? Am I going to kill somebody? Because every drug, man, seizure meds, antibiotics, NSAIDs, benzene, the worst thing ever. Aplastic, immune disorders, got it. Right. A bunch of other things. Almost anything can kick this off, it looks like. Right. There it is, your lab. Right. So again, the hallmark of this is pancytopenia. All your cell lines are affected. If you look at your peripheral smear, do you see anything that's going to grab your attention? Do your cells look normal? Right. We're talking about a normocytic, normochromic process here. The stuff looks normal, and they are normal. I lack. I don't have the numbers. So this is not a quality issue. This is a quantity problem. Aplastic anemia. There it is. Differential, sure. So we'll talk a bunch of these processes here. We're going to talk about in the oncology portion of this. So the next section, we'll talk about MDS and leukemias and myelofibrosis and the lymphomas. There you go. So management. If you know what's causing it, let's get that out of there, right? Find the offending agent, eliminate it. Immunosuppressive therapy. And then ultimately, is it so severe, is it so lasting that they need a transplant? And in the interim, are things so bad that I need to give them some blood products? Are they so anemic that they need an RBC transfusion? Are they having a bleeding issue that I gotta give them some platelets? Any questions on aplastic anemia? So think of it as bone marrow failure. Right, all my cell lines are shut down, not producing enough, and it can lead to, figure it out, right? If I'm not producing enough RBCs, what do I get? I get anemia. If I'm not producing enough platelets, what problem set am I dealing with? Bleeding. If I'm not producing enough WBCs, what's the problem set? Infection. You guys got this. All right, hemolytic. Premature destruction of our RBCs. So, plus or minus normal, right, appearance, but at the end of the day, they're being destroyed way faster than they should be, right? Is it an intrinsic problem or is it an extrinsic problem? So the intrinsic problem, the defect is with the RBC itself. There's a problem with the RBC. It's intrinsic to the RBC. In the case of hereditary spherocytosis, it's the RBC membrane. G6PD is a deficiency in an enzyme inside the RBC. Intrinsic, or is it extrinsic? Is there an autoimmune process with antibodies external to the cell attacking the cell? Okay, you guys got it? Intrinsic versus extrinsic? All right, so hereditary spherocytosis and hereditary elliptocytosis. Here, the pathological state is the spherocytosis. Right, I included that here kind of for your awareness because it exists, but the majority of what we're going to focus on, the bad stuff, we're talking about hereditary spherocytosis. Okay? And I'll point out the differences. Again, inherited disorder affecting the RBC membrane. RBC membrane defect, you get this spherical shape, I'm going to show it, right? Smaller than normal cell that's highly concentrated. Elliptocytosis, you get an elliptical shape. Right. Got it. Loss of membrane surface area. If we go back to like the day one lecture, right? What's the shape of the RBC, normal RBC? Biconcave, right? What was the benefit of that biconcave? Right, so one, surface is the area to volume, so I could hold more, right? Two was the ability for it to deform as it passes through these small blood vessels. Because of the RBC membrane defect with hereditary spherocytosis, the cells cannot deform as well. So they're more likely to get destroyed as they're passing through. There it is, less deformable. Osmotic fragility, we'll talk about the test. And again, because they're different, they're prone to hemolysis. This membrane is not as good, and then the body sort of identifies too, right? So the spleen is very judgmental, right? Spleen doesn't like things that don't look the way they're supposed to look, so it gets rid of them, right? I got a funny looking RBC here, I need to get rid of you. I got a funny looking platelet here, I need to get rid of you. Right? All right. Clinical manifestations, right? Again, this is a hemolytic process, so what do I expect to see? Get some jaundice, right? They're getting anemic, the cells are getting destroyed, we know we're dealing with an anemia, got it, right? It's a hemolytic process, so yep, I got some jaundice. Okay. Splenomegaly and gallstones. All these gallstones, right? All the hemolysis, build up of bilirubin, I get stones. Got it. Elliptocytosis, kind of similar to all the stuff we just talked about, but way less severe. These patients are usually completely asymptomatic. A risk of aplastic crisis. You guys talk about parvovirus, B19, right? So this is the thing that to me, like on every test, like standardized, I always do something with some parvovirus B19, right? So it kicks off like an aplastic crisis, and in these patients, it's known to do that. All right, your lab findings. Again, not too difficult here. We're dealing with a normocytic anemia, so we know what our CBC is going to look like. We're dealing with a hemolytic process, so we can kind of figure out what my chemistry panel is going to look like, right? Coombs, what's our Coombs test? Yeah, stumped you guys, finally. Feel good, feel good. All right, so we'll talk about Coombs a little bit more, but no, so it's looking for antibodies that's coded on a cell. Right, and we'll talk about the effect of a positive Coombs. In this case, right, this is not an autoantibody problem set, right? So what would you expect your Coombs to be? Negative, right? Blood spheres, yep. So you're going to see this spherocytosis. It's going to show up on a peripheral smear. And the confirmatory test, osmotic fragility. For hereditary spherocytosis, you do not use that with HE. Right? That's strictly for hereditary spherocytosis. All right, and there's your DAT. Right? So you get some patient's blood. Yep. You see they're coded with some antibodies. Then we put the anti-human globulin in there. If it's positive, they're going to glutenate. And that tells you that, hey, the problem set here is an antibody reaction that's occurring. Right? Hereditary spherocytosis is, what's the problem set with hereditary spherocytosis? What's the problem set? It's membrane, right? It's not autoimmune, it's not an immune issue. So your DAT is negative. Osmotic fragility, right? This is kind of that osmotic fragility. This is a confirmatory test, kind of in a nutshell, right? So you get a normal cell, stick it in a hypertonic solution, get the hereditary spherocytosis cell, and this is where we say, hey, they're more likely to lyse. Right? These cells don't deform easily. And then, so this is what we're talking about. So normal cells. Here is one that has the effect of the spherocytosis. Smaller, more concentrated. Right? But they don't deform well. And so it's because of that membrane issue, they lyse. Again, versus the ellipto, right? So looks similar. These tend to be way less symptomatic, less of a problem set. This is where the true problem set lies, the spherocytosis. How do we treat? Supportive care. Got it. Why folic acid? You're losing cells, you're lysing cells, right? So I got to replicate, so I'm using up my folic acid continually because I'm having to make more cells. As I lyse cells, the body says, what? Oh, I'm lysing cells, I'm losing cells. I need to produce more cells. You need folic acid to produce cells. Right? High turnover rate. Transfusions, maybe, right? Is it bad enough? Are they going through a crisis state where they're lysing everything and they need a transfusion? Right? splenectomy in severe cases. That's pretty severe, right? Spleens taking all these cells out of circulation. These people need transfusion like every other week or something crazy, whatever it is. Right? So you say, hey, we're better off getting rid of the spleen. And then when we talked about the spleen and its role in fighting infection, right? Phagocytosis, right? Removal of encapsulated bacteria type stuff. So if somebody's spleen isn't there or it's not effective, then hey, do we need to put them on some prophylaxis? And that's what this is telling you. No, you don't need to. I'm not testing on any of that, right? But just understand, hey, if the spleen is not working, they're more prone to certain infections. Right? Prognosis. Yeah, overall, long term, sure, generally good with treatment. Ellipto varies, yeah, they do okay. Got it. Any questions on that? So membrane problem, spleen says that these cells aren't quite right. I'm taking them out of circulation, causing this hemolysis, extravascular hemolysis. Everybody good? Good, marching on. G6PD deficiency. Yes, for everybody who needs some sort of biochemical pathway in their life, right? Good. You need this G6PD, right, glucose-6-phosphate dehydrogenase, this enzyme, to do this conversion of hydrogen peroxide, right? Because at the end of the day, this kind of stuff is very oxidizing. It's very reactive to the cell. It's going to cause problems for the cell. So you have to need this enzyme to do this conversion, to turn this into water. So guess what? I'm not causing an oxidization in the cell. I'm not stressing the cell. X-linked. When you guys see X-linked stuff, what do you think? Who's more likely to be affected by X-linked, men or women? All right, but we got one X and they get two. So if they got one good one, they usually do okay. Right? Most prevalent human enzyme deficiency. Most prevalent, right? All right. So G6PD deficiency renders the RBC susceptible to oxidative stress. I don't have the G6PD to do that nice little pathway conversion. The cell takes a hit, and now it's, uh-oh, there's a problem. Right? Accumulation of free radicals, yep. Oxidize the hemo, and we'll talk about these. This picture up here, these are Heinz bodies, right? So you get these, the oxidization of the hemoglobin, and it produces those Heinz bodies. You get this denatured DNA. Oxidative damage to the RBC membrane, right? So now again, kind of with spherocytosis, rigid, non-deformable membrane, removal from circulation. Things aren't quite right. Here we go, I need to get these out of circulation, right? Triggers, anti-malarial stuff. Again, fairly common antibiotics, sulfur drugs, macrobid. And the classic one for this is fava beans. That's the one that like put on every test. Dude ate some fava beans and then he went into like a hemolytic crisis. What are you dealing with? That's G6PD to proven otherwise, right? Okay. Acute hemolytic anemia triggered by oxidative stress. Right? Is it an infectious process? Did Knucklehead Joe Ball give him a medication that tipped him over the edge? Right? Because I didn't realize that my patient was G6PD deficient. So I said, hey, here's some sulfur drugs for your skin infection. Right? Again, man, we have to be real life stuff, right? We have to be careful about what we do. Right? It's a hemolytic process, so I get jaundice. Why the dark urine? Why the flank pain? Hemoglobinuria, right? And flank pain. My kidneys are taking a hit. Right? That hemoglobin is toxic to your kidneys. Right? Your kidneys got to filter all that excess hemoglobin out there so you get flank pain. So again, clinically normal in the absence of triggers. I'm G6PD deficient, I'm chugging along fine, I get some sort of infection going on, boom, triggers it. I go see Joe Ball, who doesn't know what the hell he's doing, and he prescribes some medication to me that tipped me over the edge. Something triggers it, and they go into a hemolytic crisis. And it can be mild, or it could be pretty severe. Normocytic anemia, Heinz bodies on bite cells. On your peripheral sphere, those Heinz bodies, we saw the picture of the Heinz bodies, right? That's that denatured DNA. It's a hemolytic process, so you know what's going to happen there with your markers for hemolysis. Hemolytic process, is your retic count high or low? High. All right. Management, yes. Avoid the triggers. Got it. Treat infections, yes. Hydration. So this becomes hugely important too, like if they're going through an actual crisis, because like we talked about. Right? Hemoglobin filtering through the kidneys, their kidneys will suffer, right? So you got to keep them well hydrated. Confirmatory tests, yes, enzyme. And you see there, most of the time it's self-limited. So most of the time they'll run its course and they're carrying on smartly and wait for some other PA knucklehead to send them over the edge. Any questions on the G6PD? So the body lacks this necessary enzyme, cells are susceptible to oxidative stress, something triggers it, and then they go into a hemolytic crisis. All right, there's your Heinz bodies. All right, this is what we talk about. So again, the spleen, not liking stuff that doesn't look like everything else, right? As they filter through the spleen, they squeeze through, and the spleen takes out the Heinz bodies, and you end up with that. And that's a bite cell, right? Spleen takes a bite out of the cell. All right, sickle cell. What do we know about sickle cell? Absolutely nothing. Good. What was that? All right, hemolytic anemias, right? So sickle, one of these hemoglobinopathies, genetic disorder, right? Sickle is a genetic disorder that affects your hemoglobin. All right, there it is. Most common form of sickle cell disease, yes. What's the difference between the sickle cell disease and sickle cell trait? Trait, you're heterozygous, so you don't have the one gene for it. Right? Most people with trait do okay, but you gotta be careful. All right, patients heterozygous sickle cell trait, typically not anemic and typically do okay. Still gotta keep an eye on these patients, and we test these patients in the military, right? We make sure. So I went to boot camp a really long time ago, right? Great Lakes, in the summertime. You get in there and you know, you're in your bay and the company commander, drill sergeant, whatever you want to call him, comes in. Everybody push your racks back and PT you to death. We're gonna make it rain in here, right? And they're smoking you till you can't believe it type of crap. One of the kids turned out to be sickle cell trait, right? So like on week 2 or whatever, he comes back positive. They're like, oh no, we can't PT this guy, right? So while we were getting our souls crushed, they would give him a little chair, and he would sit down, and they would hand him a glass of water, right? And he would get to watch us just get smoked, right? And this dude was like a problem child. Like he just did stuff that always caused issues, so we always got smoked, and he got to like drink cold water. About another 2-3 weeks went by, came back and said, you know, we made a mistake. Your test, you're actually good, you're good to go. We were like, game on, brother, game on, right? You got to join in the fun. But you have to watch these sickle cell trait people, you gotta keep them well hydrated. All right, so patients who are heterozygous sickle cell trait tend to do okay. Homozygous, they have the disease. Sickle, why do we call it sickle cell? Shaped like a sickle cell, right? And this is the issue, right? The basal occlusion. We're going to see where that causes a lot of the problems that's here. And the cells are prone to, again, they look different, they're prone to hemolysis. All right, inherited, there's your whole path to this slide. So in certain environments, and you can go through the genetic of it, right? Point mutation, got it. replace your glutamic acid for valine, got it. I don't really worry about stuff like that. It's not gonna change what I do, right? But in low oxygen environments, in acidic environments, these cells are gonna sickle. And the problem set here is instead of having this nice flow through your blood vessels, there's vaso-occlusion that's occurring. Right? Sickle, they become trapped in the vasculature, they block the blood flow. So you get a bunch of little infarcts depending on where that blood was flowing to. Right? Removal from circulation, 10 to 30 days. What's the lifespan of a normal RBC? 120 days. These babies are lasting 10 days. Right? So, yeah. Can the body keep up with that? Right? So you end up being anemic. Again, hypoxia, acid, right? Those types of environments. Dehydration, and that's why you have to be careful with kids, right? Who are sickle cell trait. You want to go play sports. Yes, go play sports, but you gotta stay hydrated. All right, there's the oxidation curve if you really want to get into the nitty gritty of the whole oxygen affinity deal. Me personally, not so much. Knock yourselves out. All right. Again, trait, one gene, asymptomatic for the most part. But sudden exertional death, athletes, right? Heat stroke, rhabdo, they're more prone to this kind of stuff. Rest and hydration. Yes, and in the military we make sure, because we like to torture people, so we have to make sure we're cleared hot. Vaso-occlusion, right? So again, get back to that vaso-occlusion. Where is that occurring? If it's occurring in the heart, then what? What am I dealing with? Right? Potentially an MI, right? What if it's in the brain? Stroke potentially. Avascular necrosis, splenic infarcts. We're going to talk about this too. These kids, often their spleen gets hit so many times that they become afunctional. Day after day after day, like every couple of months, I'm getting a hit. Right? I'm having a vaso-occlusive crisis, right? Cutting off the blood supply to that organ. It doesn't turn out so good sometimes, right? Priapism, right? Blood flow into the penis and then it's stuck. Well, not so good, right? No bueno? Probably no bueno. Probably no bueno. Yeah, I'll go with no bueno. Pulmonary embolism, PE, right? Is in the lungs. Where is this vaso-occlusion taking place? And why sepsis? Why sepsis? You get this right, you don't have to take the test. I'm lying to you, though, right? But why sepsis? Spleen. What about the spleen? Yeah, so a lot of times like their spleen is afunctional, right? Their spleen is not effective. And what's the spleen role in infection? Right? Encapsulated bacteria, opsonization, removing. So if their spleen isn't working, they're more prone to infection from some of these diseases, from some of these bacteria, right? All right. Again, this is all kind of going with the vaso-occlusion, right? Is it happening like in the lung someplace, right? Acute chest syndrome. And you'll get these patients, you work in the ER, you'll get these patients that come in and they're miserable. And you gotta hydrate them and give them some pain meds. Right? And in medicine, like we went through a period where like everybody got pain meds, and then we got really reluctant to want to give people like, narcotic pain meds. These deserve some narcotic pain meds. Right? Don't be stingy with these patients. They're miserable. And then have they tipped into an aplastic crisis? Right? They're having a rapid drop in their hemoglobin levels. So one of the things you guys make sure you do too, right, is when you see patients, if this is a patient that's been in your facility before and you got some labs, what would their labs look like the last time they were here? Right? Because that way you'll catch a trend. Something's going on, and they say, last time they were here, their hemoglobin was 11, and this time their hemoglobin is down to 9. What's going on? Right? Whatever it is. Always try to compare it to something else. And then splenic sequestration, right? Kids, and this is what happens a lot. But if the spleen takes in all that stuff too, right? Not good. Their crit drops real quick. can lead to hypovolemic shock and death. Pretty sure that's bad. Right? Don't want to happen on my watch. All right, more presentations. We hit on the functional asplenia, chronic pain, all these repeated infarcts. Right? Chronic renal failure, yes. Again, just depending on where it's hitting, right? So this is why sickle cell is such a bad disease. Right? Lab findings. It's a normocytic anemia. You're good. It's a hemolytic process, so you know what your retic count's doing. You're good. Smear. You can see these fragments, these Hal Jolly bodies. Why are these still there? Because the spleen isn't functional, right? Normally the spleen was like, I gotta get rid of this stuff. It looks different. This one's different. I need to do something about it. But the spleen isn't functioning. And then you can get these target cells also. Hemoglobin electrophoresis. Yep, shows the S. Hemoglobin S. So again, inherited disorder, autosomal, right? You can kind of go down the pathway. Do they have one? Do they have two? Is it trait versus the disease? In what environments are you going to see that sickling? What's going to set it off? Hypoxia, dehydration, acidotic environments. Something's going to trigger it. Right. And then again, just depending on what organ system it's impacted. Is it all of them? The Hal Jolly bodies we talked about, the nuclear ribbon. And again, if your spleen isn't functioning, they're more susceptible to particularly encapsulated bacteria. Treatment. Are you going through a crisis at the time that they need a transfusion? Again, folic acid, you're having this high turnover rate. These cells are lasting how long? 10 to 30 days, right? I'm having a high turnover rate. Preventing, right? Prevention is always worth better than curing type of stuff, right? Lifestyle modifications. Don't do stuff that you know is going to tip you over the edge. Oh, you want to run a marathon? Sure, you better hydrate, right? And then hydroxyurea. Pain crisis, hydration, analgesics. Yeah. And is it bad enough that they actually need an exchange transfusion? All right. Treatment. Kids, again, if their spleen is non-functioning, do we need to protect them, right? Prophylactic antibiotics early on. And then, is it so bad that they need a stem cell transplant type thing? Sickle. Any questions on sickle? Did you guys just learn anything, or did you guys know all that stuff already? I feel like I'm just repeating all the classes you guys had already. Should we just stop teaching hematology altogether? No? Ow, that hurts. All right. Oh, geez. Autoimmune hemolytic anemias. Autoimmune. Is your DAT positive or negative? Positive or negative? Positive. It's autoimmune, right? You deal with some antibodies here. All right. Autoimmune hemolytic anemias. Right? So hey, when you guys like think about these problem sets too, go back to the name, right? The name is the key and the clue to everything. You're dealing with an autoimmune hemolytic anemia. Autoimmune, so hey, I'm producing some antibodies against my own stuff. Got it. There's anemia going on, so I know what my labs look like, hemoglobin and crit, right? It's a hemolytic process, so I know what goes along with that too, right? So go back to the names if you get stuck anywhere. All right, so we're going to talk about these three: warm, cold, and the paroxysmal. All right. So warm. The majority of the time when you deal with problems that, right, up to 80% of the time it's warm. It's IgG. So you got this IgG antibody that's now coating the red cell. So the body is saying, oh, I need to get this out of circulation. Cold agglutinin tends to be IgM. Right. Typically older patients. PCH, right, tends to be IgG, tends to be merely complement more than anything else. Alright. Symptoms of anemias. You guys know this already. Alright. Fatigue, weakness, shortness of breath, sure. Jaundice, it's hemolytic, yes, you got it. Alright. Some warm. Alright. Yep. No surprises there. It's a hemolytic process, so yes, I'm having some jaundice, I'm getting some hemoglobinuria. You can talk yourselves through all these. Cold, similar. Key with cold is this acrocyanosis. What's acrocyanosis? Yeah, so when you're exposed to the cold, right? Pain, numbness, tingling, fingers, toes, right? Fingers, nose, start to turn a little bit bluish, right? So that's what triggers these, right? So obviously cold, right? You go into a cold climate, cold area, whatever, step outside like weather is now, whammo, right? PCH kind of up and down. PCH tends to be a complement thing. Usually what happens with PCH is you go to a cold environment and it activates the complement, and then when the body re-warms to normal temperature, whammo. Autoimmune, yep. DAT is positive. No surprises on the labs, right? Hemolysis, you got it. Your retics count because the hemolytic process, or you deal with a normocytic anemia. Treat your underlying condition, avoid the triggers. Right? Stuff like this is avoided. Here's your DAT again. You guys know the difference between direct and indirect? So with the direct is, it's the patient RBCs that get coded, and then we're adding the anti-hemoglobin. When you're doing an indirect, you're looking at the patient's plasma, and then we add some sort of cell component to go check it. All right, how are we doing on time? Yes, we sailed through that. You guys crushed it. Made it easy for me because you didn't ask one single question. All right, acute blood loss. All right, this is fairly straightforward. Right? If I don't have blood, I don't have hemoglobin, then guess what? Right? Rapid loss, decreased circulating RBCs, sure, but what's the cause, right? Is there some hidden cause? Well, you got this, GI bleed that nobody knows about. Is this a trauma? Shock. What's our symptoms of shock? Yeah, you guys know this stuff. Pallor, dizziness, fatigue, that goes along with any hemolytic process, any anemic process potentially. All right. Again, it's blood loss, right? So normal RBCs, I just don't have enough. So I'm dealing with a normocytic normochromic process. Pretty straightforward. But it's anemic. I've got to the stage, right, where I've seen the reaction. So my hemoglobin and crit is low. Early on in a trauma situation with blood loss, what does your hemoglobin and crit tend to look like? Normal, high, low, what? Yeah, it's meant to be normal, right? Because if it's a trauma situation, you're not just losing RBCs, you're losing plasma and everything else with it. So your hemoglobin and your crit actually looks fairly normal early on. And how do you treat the blood loss in this case? They need a transfusion. Stabilize. You guys are ER medicine now, right? You're talking about stabilizing and surgery, you should too. But that's the key, right? They lost a bunch of blood. And what's our number one blood product these days? What do you want to give? Whole blood, right? So again, when I started out growing up, it was like, all right, trauma patient, throw some IV fluids on them, right? We used to throw IV, like, let's pump them up with some IV fluids. Let's volume expand them. What are you doing when you're throwing all that IV fluids in them? Diluting out there, you're blowing the clots, you're diluting it. Right? Whole blood is the way to go now. Right? And that's what we transition to for the most part, right? Especially trauma situation. Right? On the team, the guy's jumping in, right? Carrying that golden hour bag. I'm carrying 2 units on my side jumping in, right? Normocytic anemias. Any question on the normocytic anemias? aplastic anemia, what's aplastic? You guys know all this stuff, right? The acute blood loss, fairly simple. Go back and take a look. If you're not tracking on the anemia of chronic disease, anemia of inflammation, go back and take a look. If you have questions, hit me up. Right? Because that's the one that people tend to get stuck on when they start to think about the iron, because it's kind of, it isn't intuitive the way the iron reacts, right? And simply because you have to think of it from the terms of the body's trying to keep iron away from the body. If you think about the iron in that way, it'll make sense to you. All right, aplastic, the hemolytic stuff, yes, early recognition, and treat, and avoid when possible. Any questions on anything? All right, game on. Thanks, guys.